This is the second installment of the Brady EMS Educator podcast series. This one's called Pathophysiology Overview for the EMT Educator. My name is Dan Limmer. I'm here with Joe Mistovich. We're actually recording this in Syracuse, New York, after doing an afternoon presentation at the New York State Vital Signs EMS Conference on the education standards and teaching pathophysiology. We had a really great session in which we talked about some general concepts of the standards and teaching, and then specifically going over what's new or what's different in the pathophysiology that we'll be teaching the EMT under the education standards, where, as we've said in the previous podcast, pathophysiology plays a much more significant role in that. And Joe, I've got to tell you, you did a lot of that end part of the pathophysiology presentation, and the response was really good. What I think was probably most significant is the way that you explained it. Everyone walked out and said, "Oh," they didn't say, "My students will never get that." And I think it's very noteworthy to say that if we teach it with relevance, and if we teach it, passionately, and we show the importance of it, maybe put in some case studies and really make it understandable, pathophysiology is not as big an obstacle as a lot of people think it is.
I think a lot of people walked out not being afraid, but actually embracing the idea that I could make this relevant. And as you said, apply it clinically. So what difference is this going to make in the student's ability to assess a patient and so forth? Matter of fact, at the end of the session, I talked to one of the educators, and she was asking me, how do I use this in my practical? And it happened to be another educator standing there who quickly said, well, geez, I'm going to do this through my case studies. And so now when a student's doing a case study or a scenario in the lab and they're trying to come up with, a differential diagnosis at the EMT level and they're going down the wrong track, I can challenge them on, well, wait a minute now, you have a warm and flushed skin and you're saying this is a hypovolemic patient, is that right? And so, he had already grasped the idea that he could challenge the students and he can make a big difference in their ability to more accurately assess the patient. So again, I agree with you. I think it was real well received, and instructors are now saying, students could understand this and they could apply it.
And I think your example of having an instructor engaged in it rather than hesitant or trying to dance around pathophysiology, and sometimes it's because of her own uncertainty in the early stages of doing it. I think really delving in and making it happen and not being intimidated by it is probably a lot of the message that some of those educators gave us today.
And I think one of the important things that both of us actually emphasized in our sessions was that this is not a one-shot presentation. This was a foundation that had to be integrated in all the clinical chapters. Anytime that you're talking about any clinical topic, you had to integrate and bring back that pathophys, where students could explain it forward and students could explain it backwards. And the example used was the flushed skin. That's, warm and red. And you could say, well, your patient has warm, red skin. What does that mean? The student should respond, well, vasodilation. Or the other way you could say, in this condition, the vessels are going to dilate. Well, the student should immediately say, well, I'm going to see warm, flushed skin. And I think they got that concept.
No, I do. What we've done for the remainder of this podcast is we've taken the instructional guidelines that go with the education standards in the pathophysiology section, and we've gone through. One of our realizations is that since the 1994 EMT-B curriculum came out, it really seems that we have evolved into teaching some of the material that's in the instructional guidelines in pathophysiology. There's some things that we do, but we've gone through and highlighted what we believe is the most significant change, and what I think we could also say is probably some of the more important things to teach, some of the challenges that we're going to have, and we're going to just go through those instructional guidelines as the remainder of this podcast to give you, the educator listening to this, an idea of what pathophysiology looks like. As an educator, I think we could say that we're going to do a whole presentation. We're going to just give you the big overview now, and then in the next podcasts, we'll break down the actual teaching points of the individual pathophys.
And I think what you're going to find, and I think we're hearing it, in some of the audience today, that they're teaching a lot of this already. But I think the piece that's missing is the clinical application part. And as Dan said, a lot of this that we're going to go through today is pointing out what really we believe the educators might not be teaching or what they might need to be emphasizing more.
All right, so in the instructional guidelines under pathophysiology, something as simple as the composition of ambient air, we've done part of that. The oxygen and nitrogen and the way air is when it moves in and out of the body, we've done that. But we've added, haven't we?
We have. And two things that are added in that composition of ambient air, and I don't think there's any instructor out there that doesn't teach there's 21% oxygen and 78, 79% nitrogen.
There's 21% oxygen? Sorry.
So most instructors have been teaching that for years now. And two things that are added in there is the fraction of inspired oxygen and fraction of delivered oxygen. And one of the reasons why that was added, because let's face it, a lot of EMTs actually do transfers. And they take patients from one point to another point. It might be from the hospital to a nursing home, might be from the one type of emergency department to a trauma center, or whatever it would be. And a lot of times when these EMTs are taking these patients, the physician may have written an order, or the nurse says, well, make sure the FiO2 is greater than 0.50. And the EMT might stand there and say, well, what does that mean? Well, that's simply the fraction of inspired oxygen. It's no different than the percentage of oxygen that you're delivering to the patient. However, it's expressed in a decimal instead of a percentage. We breathe 21% O2. That means we're breathing an FiO2 of 0.21. So if the physician writes, get as close to an FiO2 of 1, it means deliver oxygen to as close as a delivery or percentage of 100%. And then the fraction of delivered oxygen simply is if you're ventilating the patient, you have the patient on an auto ventilator, whatever it would be, the fraction of delivered oxygen just means that you're actually providing it to the patient through a mechanism of ventilation.
I think that sometimes the terminology makes things worse than it really is, because it's a concept people really already have a sense of. I mean, people have argued about the percentage delivered by a non-rebreather mask on test for how many years, how much you actually get through a non-rebreather. So the concept of delivered is not that different than the percentage, but we're kind of looking a little bit more into a more intelligent healthcare realm almost, it seems.
Yeah, and it was added in there primarily, and again, we don't expect the EMTs to now come into the emergency department saying, well, I was delivering an FiO2 of, 0.35, because they don't have the ability to do that. But, one point, though, is with the Venturi masks that were added in the new education standards, now we actually can deliver very precise concentrations of oxygen. And there may be a time, and again, the Venturi masks were added in thinking that the EMT is not going to pull a Venturi mask out of the scene and use it, but it might be a piece of equipment that they're going to be asked to use during a transport. And with that, it might say that the patient's on an FiO2 of 0.24. If the patient displays any distress, increase it to to an FiO2 of 0.35 or whatever it would be, and they would have to change the entrainment valve to do that. That's the primary reason why that was addressed, so that EMT has an idea of what this is. It is a very simple concept.
And I think to keep a perspective here as people are listening to this, because it's a simple concept, we're not spending 2 hours on those 2 bullet points in the instructional guidelines. Simple concepts only take a little bit of time, and then they are taught, and they are practiced, and they are tested in relevance to that importance to the practice of the EMT. All right, so we're going through and looking through the instructional guidelines here, and patency of the airway, anatomical considerations, how airways are obstructed, causes of obstruction. There's a lot of things that we really think that we have covered relatively well before, and aren't going to be a significant change if you're just going through the instructional guidelines.
Right, and I think this is actually, we've been doing a better job of covering this, and I think that's been since the registry put out that addendum to the old DOT curriculum, when the registry was finding that one of the poorest sections on the registry exam was, dealing with airway and ventilation, where the testers couldn't, select the correct answer whether they should ventilate or not. And the registry put out an addendum, and I think they corrected a lot of this, and they added a lot of this information in there. One of the other things, too, that we think that instructors are already covering pretty well is respiratory compromise, where there's a change in the structure function of of, the anatomy, the pleural lining, the muscles of ventilation, and also identifying accessory muscles of ventilation too. That's pretty much being taught already.
You spent some time today talking about the pleura, and we've talked a lot about what they are, and I can picture the slides that we've always gone through traditionally in our slide sets with the books, but there really is more of a relevance there, isn't there?
Yes, and we've talked about the pleura for years. I know even being a young EMS educator, we'd always teach them about the visceral pleura and the parietal pleura and so forth. But a lot of times we fail to mention the importance of the pleura in the pleural space. We always, it's kind of funny because I was always, well, the pleural space isn't a real space, it's a potential space. And I think for EMTs, that's pretty much the extent of what they would always learn. But now in the new education standards, they really get a lot more involved with students understanding the changes in pressures in the thoracic cavity, in the lungs, and in the pleural space in relationship to ventilation. In order to understand chest injuries, and especially like a pneumothorax, it's really important that they understand the concepts of changes in pressure in the pleural space, changes in pressure in the pulmonary structures, and so forth during inhalation and during exhalation.
And so this is something that will be mentioned perhaps in the pathophysiology lecture initially. Then it will be discussed again in airway in reference to moving in and out of the chest and that deeper and better understanding. But it's coming back again. It's coming back, anything from spontaneous pneumos in medical chapter and a differential for chest pain to really understanding why, and I saw you teach today, and we can talk about this one another time, but why flail chest does what it does and why tension pneumos happen. The thought of sealing a chest wound, the old 3 and 4 sided, valves, I mean, it really comes down to these pressures and how and where air moves in and out of the chest, and that the purpose of this is to be able to really be able to understand those things that we've had people memorize for all these years.
Right. And like I said, I think, we were selling the students short when we were teaching them about these linings and this space, but never really explained the importance of the space. I think the students thought that if you poke a hole through one of the pleura, they didn't understand why air was really going in, why air would continue to collect. As you said, if you have an open wound to the chest, why it was so important to occlude that wound. And what this really does is it really clarifies that for them.
Also on our screen is the fact that the difference between inhalation and exhalation as an active or passive process. And let's just very briefly say that all the work and all the things that you're going to teach about ATP and energy really comes into play there too, because of the fact that some of these things are active process. They require muscular contraction and they require energy. And those are other things that are here. Not that we haven't taught that, but we haven't really related the fact of the why and the how and the why and how ATP and how energy works into the breathing process itself. I think these are good reminders for educators and a good guide to be able to remember to do that and see the priority.
And I think a lot of times educators would get to the point where they would say there's muscular contraction, therefore there's work involved in inhalation. In exhalation, there's no work involved because the muscles are relaxing. But now I think what you're saying too, Dan, is they're going to start seeing this in the respiratory chapter.
Yep.
When we have airway resistance problems, and we're shifting now from an active process of inhalation to becoming a real active process, and exhalation now shifting from a passive process to an active process. And the importance of this is how that relates now to the patient going from respiratory distress to respiratory failure.
And I've had the good fortune to listen to your lectures for a long time. And the one that I heard this weekend here in New York was about the amount of energy it takes for the COPD patient.
Right, the emphysema patient.
The emphysema patient. How much energy?
It's about 75% of their caloric intake goes for them just to breathe.
That's what we're talking about.
Exactly.
That type of understanding is what we're talking about. So as we move on to our next section, and it was a 2002 Airway supplemental module the National Registry put out, and things like minute ventilation and alveolar ventilation, dead airspace, that was included in that supplement that came out in 2002. and we did need that jump start back then for Airway. And I think we've picked that up quite a bit and brought a lot of understanding as a result of that. So this stuff that we see in the instructional guidelines about minute and alveolar ventilation and the subsets of those shouldn't be really new. If people are teaching what's out there now, I don't think that there's any big surprise.
No, I don't think so either. And I think you've seen in the last couple editions of the textbooks, and it's even gone beyond the last editions. I think you're looking at the editions previous to that. You've seen minute ventilation and alveolar ventilation addressed. Extremely important concepts when it comes to making a decision whether to ventilate or not, making decisions whether your patient is adequate breathing or not. Extremely important concepts of understanding that patients can't make up for their, ventilation volumes by increasing their rates. But you're right, though, Dan. This has been out there for some time, and the registry actually, really brought this to the forefront with their supplement. And I think all of the books we've done and so forth have addressed this, and I think the instructors have also addressed it pretty well.
Some the next sections that we see with some changes that we've highlighted as significant, the effects of inadequate tidal volume and inadequate respiratory rate, and obviously you have to have adequate volume and adequate rate to have adequate breathing. And I think we've said that a lot, but in the last section we just talked about, when we talk about all those volumes and we explain those, there really is a significant clinical implication and application for that. I mean, it really is important.
And I think that's the difference with the new education standards versus what the registry had put out, and what we've already been addressing is now, again, applying this to the patient, applying this to the clinical setting, and really distinguishing between the minute ventilation and the alveolar ventilation. I mean, let's face it, we could have a patient who has a tidal volume of 500, breathing 12 times a minute. Their minute ventilation is going to be 6,000. And a student might say, well, okay, so I understand that concept. So if my patient's tidal volume drops to 250, but they increase their respiratory rate to 24, the minute ventilation is the same. They're moving the exact same amount of air in 1 minute. But if you don't understand how alveolar ventilation works with the dead space, you have actually a patient who's moving the same amount of air in 1 minute, but who's severely hypoxic because the air is not moving to the alveoli. And I think that's the real focus here, is getting students to understand that and how that's going to produce a severely hypoxic patient.
And there's a lot of ways to teach that. I found myself in some EMT classes I taught putting the mathematical equations on the board. And some people will get that. You subtract out the dead air space. But I think other times you have to bring it home in other ways. There's different learners that are going to get concepts like this in much different ways. So I think this will look at this and say it's not necessarily a big challenge, but I think this is the gravy. This is the stuff that really is new and makes a difference when it's done properly.
And I think one thing that we're also going to emphasize is the relationship between hypoxic cells and poor mechanical ventilation. I think students sometimes kind of take this ventilation thing for granted and think, yeah, ventilation's inadequate, let me go ahead and I'll go ahead and ventilate them. But they're not making the connection between the importance of that ventilation and the end result being delivering the oxygen to the cell. And I think that's really what's really being emphasized here also.
All right, now we're getting into some really new stuff. The section is called Alteration and Regulation of Respiration Due to Medical or Traumatic Conditions. Big sentence. That in itself might not be as scary as the points underneath. Chemoreceptors, stretch receptors, medullary rhythm centers, and the effects of arterial carbon dioxide and oxygen on respiratory rate and depth. That is probably some of the more newest, anyways. I don't want to say it's the most significant. I mean, the concepts can be taught relatively easily, but this is a notable change that we're really getting into that level of detail in respiration.
And I think so. I think you're right, Dan, because I'm pretty confident that instructors have been teaching students about carbon dioxide and oxygen and what happens to the rate and depth of respiration when there's alterations in carbon dioxide and oxygen. But they probably really weren't teaching to the level of it's the chemoreceptor that's actually measuring that and changing, the rate and depth of respiration, and how that change occurs through the medulla rhythm receptors and so forth. So I think that's the difference there. It's not so much the concept of changes in arterial oxygen and carbon dioxide content and its effect on the respiratory rate and depth, but now it's the next level of how that change in rate and depth actually occurs, what's triggering it, how the rate actually increases, how the depth of respiration increases. And I think that's the biggest change.
And we'll have a similar change when we talk about perfusion with the baroreceptors and how we do this. The same level of depth transfers over into the pathophysiology, or as you said earlier today, it's really physiology, but we're going into a depth that we're not used to, and then taking that physiology and applying it to the medical and traumatic conditions, kind of making it pathophysiology. So the ventilation perfusion ratio is something that I can recall being taught in paramedic class long ago and thinking that was, a concept. And even in medicine, trying to determine that mismatch, and even the tests that were available, there's certainly much more now, is a very challenging concept to get and to diagnose. But when we talk about that ratio and mismatch, we're not looking to use it to diagnose a pulmonary embolus. We're looking to understand how and why things happen, whether the problem is a ventilation problem or a perfusion problem. It's really a fundamental understanding.
It is. If a respiratory therapist were to look at this, the information in instructional guidelines, they would probably chuckle a little bit because they're saying, oh my gosh, that's one area that they spend so much time on because it's so important to ventilation and mechanical ventilation with ventilators and so forth. As you said, we are approaching this with a clinical application in a very simplistic manner, saying there's a ventilation issue, there's a ventilation side, and there's a perfusion side. We're not expecting students to learn the numbers, the 0.8 ratio and so forth. That's not important. But what we really want to get them to understand is the concept, and that hypoxia results from a mismatch, as you said, either on the ventilation side or the perfusion side. And that's the whole basis for that. Understanding how hypoxia occurs, hypoxia in cells, and how it's related back to the ventilation and perfusion.
So we're looking further on. We're actually going through highlighted guidelines as we're doing this, and we went through quite a bit of things before we saw significant change. Just thumbing through. But there are a lot of things that we'll talk about just briefly that we've done before. The blood, the general composition of blood, how blood is distributed through the body, through arteries and arterioles and capillaries, and how those work. We've done that. That's been in the anatomy and physiology chapter, and it's been there forever, and I think we're good with that. But like everything else now, we're taking things to a different level. In that same portion of the instructional guidelines, now we have hydrostatic pressure and plasma oncotic pressure.
And these are two new concepts for the basic EMT, and I'm sure two new concepts for a lot of EMT instructors. And when you look at it, this explains a lot of things, especially applied clinically. If you have a patient with edema, it doesn't matter whether it's from a burn, it doesn't matter if it's from, failure, heart failure, whatever it is, you could explain that edema on these two concepts. And so this is, it is an important concept to explain how fluid moves, how fluid leaves the capillary, how it comes back into the capillary. And this is something that is new for that EMT instructor.
Microcirculation. I'm kind of lobbing these up there, and then you're bringing them home. We're a good team when we do these things. But now we're talking about microcirculation. How does that apply to the EMT?
And that's something that I think a lot of EMT instructors probably didn't get into any real depth about. I'm pretty confident here again that EMT instructors talked about an arterial, talked about a capillary, and talked about a venule. And, even in the textbooks, Dan, we know that we've talked about, alveolar tissue perfusion, alveolar capillary perfusion. We've talked about tissue capillary perfusion. alveolar gas exchange, tissue gas exchange. We've explained it, I think, pretty well. I think EMT instructors probably explain that pretty well. But now we're going to, again, another step. We're going to talk about capillaries, the actual capillaries, the influence on the capillary, the influence by epinephrine, the influence by the sympathetic or the parasympathetic nervous system, how carbon dioxide affects the capillary, and so forth. So this is a whole new level. And I think the what has been taught has been a basic foundation, but again, we're taking another step into depth and breadth with the capillary.
How would you respond to an educator that said, we don't need that depth? How would you respond to the person listening to this that says, why are we doing this? What's the point? We're adding more time. Are they really going to use this? And we've heard this before as people try and sort out what to do with this information, how to apply it.
And I think today, when I put up the PowerPoint slide of the microcirculation, and one showed a nice red capillary bed, and the picture next to it, if you could put this visual in your head, showed a capillary bed where the circulation was shut off, and it was white. And it was kind of interesting watching the audience when I said, okay, look, here's the normal capillary bed, and it's red. And what does that relate to clinically? A normal tone of skin color. But then you look at that white capillary bed, when you have these influences on the capillary that shut them down, like epinephrine, like direct nerve stimulation from the sympathetic nervous system. And all of a sudden, when that capillary shuts down and there's no blood flow through it, when you look at the visual on the screen and you go, well, that's really white. You say, well, what's the skin going to look like? Because that's the capillary in the skin. And they turn around and go, well, pale. Then all of a sudden you see the lights going on. So
we saw instructors' lights
exactly.
go on and the explanation. And I thought that was a beautiful thing today. And I guess that's why I wanted to put that question out there and talk about it here, because the relevance of this, the way things click, again, the difference between memorizing signs and symptoms and understanding why they are there is vital. It really is important. Now we have in the perfusion, we kind of moved into from ventilation into perfusion here. We didn't announce it, but I guess you'll hear where that happened. And we're talking now about blood pressure. And I think we've always talked about the equations for cardiac output and the equations for blood pressure. The vascular resistance and the cardiac output, and we've done that. But where the standards seem to take us to a different place are with the specific talk about the baroreceptors and how the body responds to changes in cardiac output. I think that's really what this section is saying.
Yeah, and I'd agree with you that we've evolved even from the old DOT curriculum, where I think instructors have been teaching, how blood pressure is derived, through cardiac output and systemic vascular resistance. But I think you're right, Danny. This goes into much more depth of how the heart rate affects the blood pressure, how the stroke volume affects the blood pressure, how preload affects blood pressure, and things of that nature. If there's a change in systemic vascular resistance, meaning, vasoconstriction and vasodilation. And here again, I think the intent is to take the student and help them understand. So if you're teaching a patient with a spinal injury, who has a spinal injury, and you're teaching about that patient, and now you provided the student with this basic information, and they understand the effects of systemic vascular resistance on blood pressure, and they understand when the resistance goes down, so does the blood pressure, and when the resistance goes down, usually the vessel's dilated, or when the vessel dilates, the resistance goes down. When you get to spinal injuries, really, when you then say to them, well, one of the things that occurs in the spinal cord injury is they lose that tone and the vessels all dilate, immediately in the heads of the students that should be popping off is, well, then the resistance goes down. And when the resistance goes down, the blood pressure goes down. So here again, instead of asking them to memorize signs and symptoms, you don't even need to tell them that hypotension is a sign of a spinal cord injury. They'll already begin themselves to put that together.
I think that's the relevance part we've talked about in introducing this podcast, that students will see a clinical relevance. Not only will that make them want to understand, it will make them understand clinical situations better. And I'll also say that over the years in EMS, we may have called vascular tone a lot of things. And we may have talked about these things in other ways. When someone has anaphylaxis, we understand the size of the container increases, and how we present that, the old pipes analogy and the fluid analogy. And there's been so many ways we've done this, and I think it makes it more technical, but I think it makes it more efficient. I think it really gives us a way to provide a deeper understanding. It's a little less theoretical, and I think that there's a benefit in doing that.
And what you've already mentioned too is we don't want students memorizing. And what this does is it takes us from students memorizing to now students actually figuring these out on their own. Like you said, if you go into the classroom and you say, okay, today we're going to learn about anaphylaxis. And let me tell you a couple things that happens in anaphylaxis. The vessels dilate because of these chemical mediators and they begin to leak. And then you say, so what's going to happen to your patient? And the student thinks, well, vessels dilate. Well, those capillaries are going to be dilating, so where's all the blood going to be? What's going to be on that capillary? Remember that picture of that capillary, when it was dilated, it was all red, so my skin's going to be flushed. And then well, if the capillaries are leaking because you learned about hydrostatic pressure and oncotic pressure, they think, well, the fluid's going to be leaking, so I'm going to decrease the volume. And if I decrease the volume, geez, I'm going to decrease my cardiac output, my blood pressure is going to go down. So one of the things that immediately they should start thinking in their signs and symptoms they're going to get is warm, flushed skin, decrease in blood pressure. So what we're moving away from is, instead of us putting up a PowerPoint with a bullet list of signs and symptoms, we challenge the students to understand and develop their list of signs and symptoms. Because you know what, Dan? 2 weeks from now, they're not trying to recall that bullet list of signs and symptoms. They have the understanding that they don't need to recall it. They understand the theory. They come up with those signs and symptoms.
And within this are challenges for the educator. I don't know, based on this conversation, if I'd say the educator's challenges are as much teaching the more difficult concepts as it is changing the way we teach to make the difficult concepts really hit home. I think that's as big a challenge as the content itself.
Right. And I think, educators, there are a lot of educators that are probably teaching cardiac output and what makes up cardiac output. But you're right. It's the change in the way that they're teaching to apply this clinically, apply it to the different types of shock. And this isn't just shock. I know I used the example today about the patient having the MI. And you say, well, if the patient having the MI has a decrease in contractility, the cardiac output's going down, what's the body going to do to try to compensate? Increase or vasoconstrict, increase the resistance. And if you do that, what's a sign you're going to see in an MI patient who has a decrease in contractility? Pale, cool, clammy skin. And then again, I think you were seeing also the instructor sitting there going, wow, that's really simple, but it makes so much sense.
No, it was really noteworthy. People, I think, may still have their ups and downs and their denial, anger, bargaining, depression, and acceptance of the new education standards. But we didn't have a single person raise their hand and say this can't be done.
Exactly.
And I think that's changing over time. So as we move to our next section, I think we're officially getting into the cell. And that's probably another one of the more noteworthy changes in this, is that now we're talking about cell metabolism and the fuels of the cell and energy and ATP. And that is different, and that's new.
That is new. And I think most, especially at the EMT level, a lot of times I think at the paramedic level even, where instructors said, well, that's up to their biology class to teach this. And I think paramedic instructors even didn't relate this clinically to the patient and the effects, and we'll get into this in more detail, obviously, when we cover these sections individually. But this is such an important concept. And Dan, we've been saying this over and over and over for the last 2 days that, basically everything that the EMT does is related to getting glucose and oxygen to that cell. And in order to understand that importance, they have to understand what aerobic metabolism is and what anaerobic metabolism is, what the byproducts are of aerobic versus anaerobic. And again, today, we applied this clinically and said, here's the difference in the presentation of the patient when they've shifted from aerobic to anaerobic metabolism. And again, I think instructors are saying, wow, that makes a lot of sense. And I don't even have to touch the patient. I don't even have to ask the patient a question, or maybe one question, and I'm starting to think to myself, They might be in shock. They might have a poor perfusion state, and because they understand the aerobic versus the anaerobic metabolism.
I think when educators picture teaching about the cell, maybe it's a flashback to biology class when you would draw the cell and then you would go through and label all the organelles and all the different parts of the cell, the structures of the cell, and say that that's what we're talking about. And that's not what we're talking about. We're talking about the relevance of fuel and ATP on the body through the cell. That we're not teaching complex cellular anatomy and physiology. We're teaching concepts that help people understand the big picture.
Exactly. It was kind of interesting in your presentation today when you put up the illustration of glycolysis and the Krebs cycle and so forth. I heard some moaning in the audience, and some of the EMT instructors sitting back going, "Huh, right. There's no way I'm going to be able to teach this." But I think, as you said, when you break it down to the level of the importance of keeping glucose and oxygen getting to that cell. Let's face it, that's our job. In EMS, that's our job. That's what we're out there for. By putting direct pressure on a bleeding injury, why are we doing that? Again, it's not because we're trying not to, get the floor messy. It's because we need to maintain perfusion of that cell with oxygen and glucose. And it does make sense when you start talking about the byproducts. And again, related to the signs and symptoms. It does make sense. And it makes sense, I think, to the student when they could apply this, and they then understand their treatments and the signs and symptoms again.
So if we're talking about the cell, then we talk about ultimately perfusion at the cellular level, rather than, like we said, the structure of the cell, and the effects of when things go wrong, the pathophysiology, the lack of glucose, the lack of oxygen, and how fundamental and simple that is, and how everything that we do, we've talked about, really comes down to those two things and the effect on the cell and thereby the effect on the organism itself.
Right. I think the bottom line is if that cell doesn't have energy, it's not going to function. If it doesn't have energy, it's not going to function right for a period of time. And as it continues with a lack of energy, eventually it's going to die. What's interesting, then we move into the sodium-potassium pump. And I think that is a new concept for a lot of EMT educators. But basically what it explains is how that cell eventually dies. And when you relate that back to energy and the production of energy, and you relate that back to glucose and oxygen and aerobic metabolism, people get it. Students get it. And what it does, it reinforces the concept of how important it is to continue to get that glucose and oxygen to the cell. And you know what that reinforces? You say, so somebody says, well, how does the student know that? But it reinforces airway management, reinforces ventilation, it reinforces oxygenation and circulation and so forth. So that's a new concept, the sodium-potassium pump, and how the cell actually dies. Very simple concept. I think it's a pretty profound concept, but very easy to understand.
And as I started looking at these education standards, now it's been years ago, we said it was the pathophysiology that people wouldn't be able to get and teach. That to be some people, as they said, left by the side of the road. And the more and more I do this, the more you and I talk about this, and we talk about this a lot, it really strikes me that it's not the pathophysiology itself that's gonna give educators the problem. It's going to be making the relevance. It's going to be driving it home. It's going to be really showing why the sodium-potassium pump is affected and how it's affected and how that affects the organism, and relating the sequence of events from what you're going to see in the patient from beginning to end and how these processes come together. It's the integration of the concepts that are probably more troublesome for the educator than it is simply to put a slide up about the potassium pump and explain how things are moved, that ATP is there. It's the bringing it home that I think is going to be the most important.
Absolutely, and I agree with you, Dan. I think that's where the educator might struggle the most. But once they begin to understand this and they begin presenting it, I think over time they'll be able to effectively integrate this into their lectures. And it's interesting. What you're saying is so funny because we say you have to integrate this. You have to make it relevant to the students. And we talk about the sodium potassium pump. But the bottom line is, as simple as if you tell a student, look, you don't have a good airway. And if you don't have a good airway, and you as an EMT, you haven't established a good airway, you know what's eventually going to happen? Cells are going to die. The interesting thing now, the student might sit back and go, how's the cell going to die because I don't have a good airway? Now they'll have the ability to understand it, because eventually they're going to understand the sodium-potassium pump, they're going to understand the metabolism, and they're going to be able to sit back. And I think, here's what I get excited about, is a student I think is going to really understand the importance now of airway management, of ventilation, of oxygenation, and of circulation, and how it's related to that cell dying.
I think that puts us at about the end of what we intended to do today, and I think that was the perfect jumping off point to stop this and break and to continue. The next podcast that we'll do is we will take the physiology and pathophysiology of ventilation in one, and then the physiology and pathophysiology of perfusion in another. And then we're going to go back and we're going to make some podcasts for your students to listen to help you as educators get that message across, to get these things out in any way that you can. It's really our desire. And why we're doing these podcasts is to make this easier, because we know that it's going to be a challenge. So thank you for coming back and listening to this podcast. And we look forward to having you come in and listen to our subsequent podcasts on ventilation and perfusion specifically.